Hello, Safura.
Kakak lead macam PBL je kan?
Hai Wawa.
Hai.
Dengar bunyi bising tak?
Tak. Tak.
Di PBL. Ya kot.
Kakak ada tanya tak group sebelum ni? Diorang buat macam mana?
Tak.
Tak.
Just yang Zati cakap tu je lah.
DDX tu lah.
But sebut kan. Kita buka whitelist, lepas tu kita sebut kan. So, okay. So next we proceed with what history do you want to ask? History of presenting illness. So, hematuria. Macam tu kan?
Saya berdebar lah kak.
Solat Zohor tadi, azan terus solat.
Ya terus solat. Takut gila. Takut start.
Betul Azamin faham kot.
Ha?
Betul Azamin faham kot. Kita dah lama tinggal.
Minta lah macam tu. Okay dah, thank you.
Okay. Kita macam mana? Tak reti lah pakai Zoom ni.
Oh semalam akak tak ada. Lupa. Macam ni je. Semalam Kak Saf ada appointment kan?
Oh, patutlah rasa tak ada yang bising.
Jahat. You je yang selalu bising.
Asim yang bising.
Mana ada?
Hello.
Raise hand. Oh yes. No. Go slower. Go faster.
Apa benda tu?
So untuk first case ni memang PGN. Post PGSN lah
Rasanya. Sebab dia tak ada kuria, tak ada flank pain. Lepas tu dia ada, family dia ada.
History kan? Tu je lah. Lepas tu hypertension tu nak indicate apa?
Tak tahu. Just
Sekadar risk factor.
history kot. Kena untuk masuk dalam DDX.
Okay.
Unpin. Tajuk.
Kak Pura.
Yes.
Kak Pura pergi Pahang ke semalam?
Saya tahu.
Dah jumpa Dr. Ismail?
Oh,
Sekarang dah balik Selangor ke?
Dah pergi balik hari. Kosong hospital. Ketat gila macam nak masuk.
Penjara.
Macam nak masuk penjara. Ramai gila orang jaga berperingkat-peringkat.
Every tingkat ke?
Every tingkat
Kat
ada.
pintu masuk je.
Dekat pintu masuk. Pintu masuk ada satu je.
Oh my god, Hasif. You memang pakai
Hasif
makeup ke?
Hasif dah Korea ke lah ni Hasif?
Ni filter lah.
Amboi.
Zoom ada
Zoom kan boleh
filter.
buat filter.
Ya ke?
Boleh buat background.
Ya.
Ya.
Reaction pun ada.
Kan ada touch up my appearance.
Faham.
Lepas tu macam mana nak hilangkan reaction ni?
Lepas tu
Okay. Dah. Okay lah dah.
No. Host kita Dr. Syed. Dr. Syed ada ke hari ni?
OMG.
Pitch Year 5 Teacher A. Host Syed Abdul Khalid.
Mana akak baca kak?
Dekat I kecil. Meeting information.
Oh ni.
Tengok background I.
Hasil buat. Pintu. Dah. Nanti I discover.
Gallery view ke? Tak.
Ada dekat virtual background.
Which one? Sekarang ni orang patut berdebar ni.
Tak
My
pun.
filter
So
pula.
sorry.
Kalau birth history, nutritional history, growth history semua kita kena sebut juga ke? Kita kena tanya orang juga.
Kena tanya lah. Tapi macam biasa, macam PBL, macam apa ni, dia fokus more on HOPI kan?
Okay.
Macam kan kadang-kadang kalau kat family history kan ada risk factor, konon ada genetic mutation ke apa kan semua kan. Kita still akan mention dekat dalam HOPI ataupun family history. Kalau dalam perbincangan macam ni.
Rasa macam HOPI
HOPI.
sebab dia related. Kalau macam hypertension kan macam ni. Kalau history of nephritis dalam family, so dia big risk factor, so masuk dalam HOPI.
So macam kalau consanguinity marriage tu saya akan mention dalam HOPI. Kita akan mention dalam HOPI.
Oh yang tu kan penting kan dalam development. So kena kot.
Kena mention lah.
Nah.
Mak nampak baju. Senyum semua. Alah ada. Masuklah.
Tak nak.
1, 2, 3.
Hasif dah habis dah?
Ya.
Tak ingat Hasif senyum lagi.
Saja je nak tanya dalam case 1 kan nama budak tu Farah.
Pasal Fiona.
Tu Fiona.
Yang Fiona tu nama juga kan?
Sama juga kes 2 pun sama.
Justin.
Justin tau.
Tapi orang sama je kan? Nama je tahu kan?
Nak tanya kalau kan dia kata renal ultrasound dia normal kan? So macam masa
waktu 4 tahun kan?
Oh tu yang 4 tahun.
Tu waktu 4 tahun. Kan?
Lepas tu yang dia yang on medication tu sampai sekarang.
Dia tak on medication.
Sebab masa tu UTI je kan?
Cuba you baca. She is on no medication.
No
no medication.
Okay. Thank you.
Asif kat mana tu Asif?
Ada kat langit.
Sekejap, tu background Asif ke Asif pakai virtual background?
I kat negara lain dah.
You.
Boleh pakai virtual background padahal. Wow, Asif hari ni very stylish ya. Sibuk je. Baru nak join. Safura baru nak join.
Yalah, haters. Amir, kes kita kan
Ya.
nama budak tu kan Fiona.
Siap.
Dr. Azamin dah ada dah.
Serius.
Dah.
Okay.
Baik, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Salam
Warahmatullahi wabarakatuh. Salam doktor.
Okay. So there's 11, so many of you kan? Ni grup mana ni?
Grup 2. Grup 2 doktor.
Grup 2 sepatutnya ada 10 people. So dia ada lebih. Ada lebih ni.
Ada seorang lagi.
From where? From, is it foreigners?
Ada.
Okay, so let's start with Ummul Kitab Al-Fatihah. Okay, so basically I just finished the 2 cases that I gave it to siapa ya? I gave it to Izzati, right? I gave it to Izzati. So there's 2 cases. So and I did discuss with group 4 for the morning session, the same cases as well. So I hope that group 4 is not here, lah. Because there's 15 of you. There's 14 of you. So I presume this is going to be group 2 plus 3. Ke ada group mana?
2 and 3.
2 and 3 ya. So group 1 tak ada sini?
Sebab tak buka ke kamera.
So we don't know who is here, who is not here lah. But anyway, as long as group 2 is here, the rest of you can join as well. Doesn't make any difference. So the 2 cases that I give it to you is basically cases from a book that I got in my laptop. But we're going to use the case as a problem-based learning. We're going to use the case as a long cases style as well. So that's why I asked one of you to lead each case. Mana akan ada 2 orang, seorang akan lead satu case. So it's mainly about the presentation, and then from the presenting complaints, then we can go further into more of what differential diagnosis that we're going to discuss. Okay. So So there is, so I presume yang buka kamera ni adalah group 2 lah.
Yes.
Kan?
Yeah.
Yang tak buka kamera tu adalah foreigners lah.
Foreigners.
Okay. Okay, so who's going to lead the first case?
Okay.
Apa?
Saya.
Okay. Okay, baik.
Okay.
Oh, cantik dia punya background dia. Ada dekat angkasa background dia.
Safe. Ya, angkasawan doktor.
You are in the different course lah. Okay, so I'll leave to Safura to lead the case, and then we can chip in. Obviously, because we are doing the online teaching, I don't want one-way communication. So kalau Safura want to ask question, then you can direct the question to your colleague. Okay.
Okay.
So we know who's actually on the bed. We know who's actually sleeping and so on. Okay.
Okay. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
For case 1, Farah is a 6 years old who presents to A&E department where her mother states that Farah's urine has been red. She has brought a jar of urine which contains what appears to be reddish brown urine. She has no dysuria frequency or abdominal pain, and there is no history of trauma. She is otherwise well, but she and the rest of the family had recently had colds. There have been no nosebleeds or abnormal bruising. She had no problems with her joints. She had a urinary tract infection at the age of 4 years, but following a normal renal ultrasound, she was discharged from clinic. She is on no medication. There is no family history of renal problems, but her grandmother has hypertension. So that's a summary ke chief complaint. Okay, so for the chief complaint, urine has turned red. That is, we can call it as hematuria, right?
Yes.
So proceed with history of presenting illness. Focusing on this hematuria first. So what question do you want to ask?
Does she feel pain while urinating?
No dysuria.
She has no
No dysuria.
Dysuria.
No dysuria.
I think first we ask about the duration and the onset of the hematuria first, right? Yes. Since when the hematuria started to appear, and the duration, for how long until the admission, and then you can ask the doctor to describe the color. Is it bright red, rose, or concentrated? Am I right?
Yes.
Okay. The other thing you want to ask?
How about the amount of the urine?
Yes, amount of the urine, whether it is increase or decrease, small or big amount. Then is there any foul smelling?
Oh, for smelling.
And is it frothy or sandy? Because we can identify proteinuria.
Okay.
What about the timing of the duration? Is it from initial, terminal, or throughout the urination? If we can ask the mother.
Yes.
Or maybe the kid itself.
Okay. Because if it is at the end of the stream, there might be lower urinary tract bleeding, right? But if it is throughout the urination, it might be glomerular bleeding.
Yes.
Some more? For the hematuria, I think all. there any addition?
How about associated symptoms such as fever, any pain along around the body, flank pain,
Any loss of weight
Loss of weight.
and loss of appetite.
Appetite. Oh,
Okay, for if we suspect infectious, we can ask whether the child herself, does she have any sore throat? Because we need to suspect streptococcal infection.
Oh.
So
Maybe we can ask other associated symptoms such as rashes that associate with Iraq's splena purpura or SLE.
Good.
okay, how about facial puffiness,
edema,
Edematous.
edematous appearance? And if we suspect hemolytic uremic syndrome, we can ask whether the child has diarrhea, oral bloody skin. So,
basically, so from the history so far, from the history that you got on that slide, what will be your differential first?
for streptococcus glomerulonephritis.
AGN.
Due to history of UTI.
Because it reddish brown urine.
Yes.
The other differential.
It can be also due to lupus nephritis. Oh,
Lupus nephritis, okay.
How about renal stone?
So you can think about renal stone as well because it is a hematuria. So let's go bit by bit. So what will be the commonest things that you are thinking for a 6 years old girl?
Glomerulonephritis.
Glomerulonephritis. The reason for that is because there is a recent history of colon. So that's why we're thinking about possibly post-streptococcal acute glomerulonephritis. So that's the main thing.
Yes.
So your other differential, what is your other differential yang quite common in children at 6 years old?
Urinary tract infection.
Okay, so you're talking about UTI, isn't it?
Yes.
Yeah. So if you suspect UTI, what are the questions you want to ask? So you're talking about foul smelling urine, you're talking about slightly cloudy urine. What is other symptoms that could be suggestive of UTI?
Frequency, hesitancy.
Okay, so you're talking about frequency, urgency, or
Painful.
hesitancy.
Urgency.
Being what call it? The feeling of not emptying the bladders completely, isn't it? Okay.
Incomplete voiding.
So you talk. The history says that there is no dysuria, no frequency, no abdominal pain, and also no trauma. Okay. So in this particular piece of information actually kind of suggestive that there's not much in terms of history of infection, isn't it? But what are the questions you want to ask to rule out infection completely?
Fever.
So you want to know is there any fever, isn't it? Yes. So any fever or not, you probably want to know about urgency, whether she can actually hold her urine until arriving in the toilet, or whether she actually wetting herself before reaching the toilet. Those are urgency. We also want to know whether there is any symptom of nausea or vomiting, because sometimes nausea or vomiting also can be associated with UTI as well, isn't it? Okay. So UTI, apart from that, you also want to know, is there any comorbid with UTI? Anything that you think could be comorbid that increase the factor for UTI? Sorry, increase the risk factor for UTI. So what is the comorbid that can increase the risk factor for UTI?
How about hygiene?
Okay, so you're talking about hygiene, okay. What else?
Anomaly.
So you're talking about possible anomaly. What kind of anomaly that what kind of anomaly that you are thinking about?
Vesico-ureter reflux.
Sorry?
Vesico-ureter reflux.
Vesico-ureter.
Okay. So basically, so VUR, so vesico-ureter reflux. Anything else? Anything else? So when we're talking about anomaly is basically something that you are born with, congenital anomaly, isn't it? Okay. So part of the congenital anomaly that we know can be associated with UTI or increase the risk factor to get UTI is PUJ, pelvic urethric junction anomalies ataupun dysfunction. That's one thing. And sometimes you can have congenital hydronephrosis as well that can lead to UTIs. Okay, so those are the few comorbids that been associated with UTI. Other common things that other common comorbid that normally associated with UTI. Constipation, yes. Constipation also associated with UTI as well. So how does constipation increase incidence of UTI?
Because the causative organism, E. coli.
But we're talking about constipation. How constipation can cause UTI?
Because of the distance from the anal tract and also the ureter is short.
Okay.
So it's susceptibility.
But that's for girls, not for boys.
It can cause obstructive uropathy.
What's the uropathy? Obstructive uropathy macam mana?
It obstruct the urination process.
Okay, so kind of on the right track. So basically, if you are constipated, okay, you basically have kita panggil dilatation of your rectum. So your rectum is fill in with the stool, with the stool, and then this rectum, because the structure of the rectum is near to the urethra. So if you got a dilated rectum, the rectum will actually compress onto your urethra. Because the compression of the urethra, it causes a blockage of the outflow, of the urine outflow. So that's why kids tend to hold into their bladder for a long time if they got constipation. So if you got constipation, you retain your urine in the bladder for a long time. And then because retaining of urine for a long time, it can basically promote colonization of bacteria because of that. So that's why constipation is a known comorbid for UTI. Okay, so those are the thing about this case. So you asked about skin rashes. You asked about joint problem as well, and then you're talking about possible head of scoring purpura, isn't it?
Yes.
Yeah. So why head of scoring purpura give you hematuria and also skin rashes and also joint problems? Mana Safura? Safura dah hilang.
Ada.
Kurang.
So, if you can also pass the question to your colleague. You don't need to answer the question.
I will pass to Amir Zahiruddin. Do you know anything? Amir.
Kan Amir senyap. Amir dah hilang.
Okay, anybody know?
What's the question again?
Oh, how HSP into hematuria.
IgA nephropathy.
No. We're talking about HSP.
Immune.
HSP.
Why HSP? Why HSP can cause skin lesion, skin rash, and also joint problem, and also hematuria.
How about the inflammatory response due to the complex of IgA and IgG?
Okay.
Yes. The deposition of IgA and IgG in organs.
They activate the complement system.
Okay. And then how does it lead to?
It will precipitate inflammatory response that leads to vasculitis.
And then?
So when there is renal involvement regarding the complement system, so it can cause hematuria.
Glomerulonephritis.
No.
No.
You're talking about HSP, you're not talking about glomerulonephritis.
I'm so sorry.
Sorry. Internet problem.
Okay, so we're talking about pathogenesis of HSP now. How does HSP, because of its pathogenesis, lead to hematuria plus joint problem plus
skin rashes,
skin rash ataupun purpura. So you're talking about complements, you're talking about inflammatory processes. So what is the basic way or easiest way to explain to parents what happened in HSP that lead to joint problem, purpura and also hematuria. So if you talk to them like you're talking about IgA, you're talking about complements, you're talking about inflammatory processes. So if you're talking about a layman person who don't really know those terms, so how are you going to explain to them about this HSP? Because when we talk about HSP, you're talking about kidneys, isn't it?
Yes.
But why kidney problems cause joint problem and also skin problem? Kan? So maybe Nur Aida nak jawab.
Aina Rose.
Aina Rose. Okay, let's go back to HSP. Okay, what is the 5 organs that involved in HSP? Okay, you're talking about kidney,
Skin.
joints,
GI tract.
So abdomen and
CNS.
and CNS. Okay, so now my question is how HSP. So I'm going to ask Aida. Aida. I'm going to ask Aida how HSP lead to hematuria.
Doctor, can I try?
Okay. Hilang lah Aida. Aida hilang.
Doctor, is it because of the antibody that causes vasculitis, so it destroys the renal circulation and causes
Okay. Okay. So do you guys understand what it means by nephritis? Ataupun nephritis lah basically. What is nephritis by definition?
Inflammation of
Inflammation of the
kidney.
nephron
Inflammation of the
in the
organ.
kidney.
Okay. Everyone agree? Nephritis is inflammation. Okay. Okay. So what does inflammation do to your kidney?
Injury.
To injury. What kind of injury?
Necrosis.
Huh? Necrosis. Is it necrosis?
Not yet.
Injury to the tubulointerstitial.
Okay. Okay. We're talking about injury. What kind of injury that you understand? Mana korang akan explain kat parents kan. So anak puan basically dia punya buah pinggan dia dah injured. So but what you mean by injury? What you mean by injured?
Leakage.
Okay, leaking. So that's the word leaking. So what we're going to see is inflammation or inflammatory or nephritis is an inflammation of the blood vessels in the kidney, isn't it? So that once you got the inflammation of the kidney, so your kidney become inflamed, or in other way you can also say swelling as well. Dia bengkak. Blood vessels saluran dalam buah pinggan tu bengkak. Bila dia bengkak, what happened to the dia punya filtration rate?
Permeability.
So increase permeability is also going to affect dia punya filtration rate. So whatever the blood supply to the kidneys, to the glomerulonephritis will be reduced kan. Okay. At the same time as well, because it's leaking, so dia dah bocor, so that's why you got the protein, the red cells all coming out from the vessels across the basement membrane going to the pelvic junction. Okay.
All right.
So that's why you got this accumulation of protein and also the red cells. That's why most of the patient yang ada nephrotic syndrome ke, kemudian nephritis ke, HSP ke, so they will got this bit of protein and also red cells in the blood. Okay. But obviously, so red cell in the urine. So but most of the nephrotic syndrome mainly is a protein that leaking. Because it's a minimal changes. So normally protein yang leaking rather than red cells. But sometimes protein also can have a bit of hematuria as well. Okay, so that's what happens in the kidney. So how the HSP lead to purpura? So Syuhada jawab.
Syuhada.
Google. I want to know.
Isn't it?
I think due
Apa
I think it is
you think?
because of the vasculitis due to the inflammation.
Because of the vasculitis due to inflammation, isn't it? So it's the same process as well. It's a vasculitis, so it's an inflammation of the vessels, of the blood vessels. The inflammation of the blood vessels make your blood vessels leaking and swelling. So increase the permeability of the blood vessels. So that's why your protein, your fluids, and also your red cells basically escape from the blood vessels and deposited onto underneath the skin. So that's why you got this purpura or rashes and so on. Okay. What about joints? Why you got joint pain in HSP?
the deposition of the complement at the
separuh, jawab separuh aja. Lepas tu senyap.
Lepas tu sambung.
deposition of the complement at the joint area in the synovium.
So the deposition of the complement cause the joint pain.
the deposition cause inflammation, then cause joint pain.
So have you seen HSP before?
No.
No.
So if you Google, let's say if you Google images of joint HSP, okay? So if you Google, so most of them will show a swollen joint. The joint is quite swollen. It's quite meaning when you got a swollen joint. Let's say if you're talking about something else, kalau joint itu swollen, so definition of swollen joint, apakah in medical term, what is it called? Swollen joint, apakah medical term for swollen joint?
Arthritis.
Oh,
Confidence sikit. It's arthritis.
Arthritis.
It's a swollen joint. It's arthritis. By definition, it's an inflammation or swelling of the joint. Okay. So there's a few causes of swollen joint. It's an infection. Okay. You got infection, could be anything. Could be septic arthritis, or it could be just a cellulitis and so on. And then you got kind of like excessive fluids in the joint, also can cause swelling of the joint as well. Okay, so in the case of HSP, yes, some theory says it's a deposition of the complements that lead to inflammatory processes in the joint that lead to excessive fluids accumulation. That's one theory. The other theory say that because of the PMBB vasculitis of the HSP, that make your protein and also your fluids leak into the interstitial space, that then lead to swelling of the joint. So there's a few mechanism of pathogenesis that lead to swollen joint in HSP. Okay, so you're talking about kidney, joint, and also skin. So what about GI tract? Why some children develop abdominal pain in HSP?
The vasculitis will cause inflammation and restrict the blood flow to the GI, and then it will have pain due to ischemia, the bowel ischemia. The bowel ischemia.
Is it? Yeah. So normally if you got ischemic bowel, if you have reduced blood supply to the bowel, and so that's why you got ischemic bowel. I'm just thinking because in HSP you don't really have reduced bowel, you don't really have reduced blood supply to the bowel. It's mainly just a vasculitis that caused that. And then sometimes because of the vasculitis, your bowels can be inflamed as well because of the vasculitis. So that's why most children can have abdominal pain with HSP. And same with CNS as well. CNS also, you got vasculitis in the CNS. Because of that, your brain can become swollen, or sometimes you can have the inflammatory processes happening in your CNS that cause brain cause CNS complication from the HSP. The thing is, CNS complication from HSP is very, very rare. I've not seen anyone who have CNS HSP complication so far. But you expect some sort of reduced GCS, possible seizures, and so on that can cause CNS complication. Okay, so those are the reason why you want to know in terms of the child has bruising and also joint problems. So in this case, the child don't have any bruising, the child don't have any joint swelling or joint problems. Why is the significance of there is no nosebleeds?
Because of bleeding tendency.
So you're talking about bleeding tendency, yeah? What kind of bleeding problem in children that you know? It's okay if you don't know. You can pass to your colleague. You got Siti Adawiyah. You got Zati. You can have Amir again.
Hasif.
other than HSP or ITP, Amir, can you name other?
Hemophilia. Boleh.
Okay. So why this case hemophilia is not really top of your list?
Because it is a girl.
Okay, good, because it is because it's a girl. So that, because you know hemophilia, majority of hemophilia is X-linked resources.
Actually,
So it tend to affect boys rather than girls. Okay, and plus the most commonest presentation of hemophilia in children is basically spontaneous bruising, gum bleeding, nose bleeding, and also joint bleeding as well. Okay? Hematoarthritis. Hematosis. So those are the most commonest presentation in children. But it does not mean that they cannot have any bleeding elsewhere in the body. So they can have bleeding in the brain, they can have bleeding in the abdomen, and so on. But the most commonest cause is just a spontaneous bleeding of the skin, joint, hematuria, nosebleed, and also gum bleeding as well. Okay. What are the questions you want to ask these children? So far we just down to she has no problem with the joints, and then she had a UTI at 4 years old. Okay, so any question up to that? Any other question you want to ask up to that? Up to 4 years old UTI. What is the significance of knowing the age of UTI at 4 years old?
Organism,
okay. What else? Mungkin Najwa nak jawab
In terms of management.
Okay, management. What kind of what is the difference? What is the significant management at 4 years old?
Prescription of antibiotic on different organism. Tak tahu.
Let's say if somebody got a UTI at 4 years old compared to somebody has UTI at 3 months old, what would be your thought process?
Congenital.
Okay, so okay, so dapat Mr. Safura tengah buat tengah study last night kan. So yes, if you got UTI at, in the early stage of life, it's likely to be congenital causes. Congenital causes means that the child might have a structural anomaly. For example, as you mentioned before, VUR, PUJ, hydronephrosis. It could be duplex kidneys and so on. So those are the difference between 4 years old compared to 3 months old children. Okay. If I got a child that comes with UTI, confirmed UTI. So UTI, what is the meaning of UTI? What is the definition of UTI? I'm going to ask Najwa again. What is the definition of UTI? I mean clinical definitions.
Growth of bacteria in urinary tract.
Okay, plus. Ada plus.
Plus.
Ada plus kan?
Plus bacterial culture.
Okay, so basically, obviously, UTI by definition is infection of either upper or lower tract of lower urinary tract with evidence of growth in the urine, isn't it? Okay, so those are definition in another textbook. For clinical definition is you got the symptoms of urinary infections, plus you got the evidence of growth in a urine culture. Okay, so most of children yang datang kat kita ni katanya ada recurrent UTI. Okay, but when you look into the records, when they send for urine culture, there is no bacterial growth in the urine culture. So if that is the case, then it is not definite UTI. It's just a suspected UTI. Okay, the definition of UTI that we normally use is symptoms of UTI plus evidence of growth in the urine. Okay, if there's no growth in the urine, then you only suspect the UTI. So it's not really a confirmed UTI. Okay, so those are definition of UTI that we should be using. Okay. Now, okay. So we go back to my question before. So 3 months old to 4 years old. So if I got a patient that come to me with UTI at 3 months old, normally I treat with antibiotics as usual, but at the same time I will do further investigation. For example, I will definitely request for ultrasound scan of the kidney. The reason for that is because it happens quite early in their life. Most likely that the reason that the child got UTI is due to structural anomaly. So you want to make sure that the child not have any VUR or PUJ or hydronephrosis. Okay, the PUJ and hydronephrosis probably can be seen by doing the ultrasound of the kidney. However, VUR, you need to have we call it apa nama tu MCUG, micturition cystolurography, because you want to know is there any reflux of the urine going back to the ureter. Okay, so you got the bladder, so you put the dye into the bladder using the CBDs ataupun urine collector. Then you see whether the dye from the bladder will go up to the ureter going to the kidney. Okay, so those are the way that you want to diagnose vesical ureteric reflux. Okay, so MCUG. Okay. Okay, so this child got a UTI at 4 years old, and following that, she had renal ultrasound, which is normal, and then she was discharged home with no medications. Okay. Any other question you want to ask this child or the family? Anything, Safura, you want to add on in terms of further question you want to ask?
Question, any family history of renal disease?
For example?
Nephritis?
Okay. Does nephritis really
Hereditary.
genetics? Apa yang
Kidney stones.
Right?
Polycystic kidney disease.
So normally polycystic kidney disease, that is hereditary. Kalau nephritis, HSP ke, kemudian nephritis ke, nephrotic syndrome ke, so it's unlikely to be hereditary anyway. Okay, so unless it's a polycystic kidney disease, so it's more congenital problems if it is hereditary. Okay, any other question you want to ask?
The question, does she take any medication such as rifampin? Rifampin for TB management.
Okay, rifampicin, isn't it?
Rifampicin. And then any laxative, Senna, or any what does she eat? We must suspect that it might be food dye.
Okay, so sometimes anything that you eat or you consume also can affect in your color of the urine as well, isn't it? So rifampicin can give you red colored urine or orange urine. And sometimes if you take aspirin or cyclophosphamide or I think cyclosporine, I think that also can cause red urine as well. Okay. Some people say if you eat beetroot, tahu tak beetroot apa?
Beetroot.
Beetroot.
Oh, beetroot.
Beetroot lah, beetroot.
Beetroot.
Yang warna purple tu
I don't know what it is lah. Tak tahu apa benda beetroot tu. Umi kledek tu.
Beetroot.
Google lah, Google beetroot. So beetroot also can cause red urine as well. Okay.
Oh.
And nowadays, you know, there's a lot of supplements been on the market kan. Orang kata apa, Magical C Pure, apa lagi, apa yang Alik Syukri apa, B-Herbs and so on kan. So there's so many products on the market that been consumed by our population. So sometimes we don't know what is the content of that, and it could be that some of the ingredient in that supplements can cause red urine as well. Not necessarily hematuria, it's just the color of the urine become red. Okay. Sometimes if you take a B complex medication or vitamin B complex, it also can turn the urine to very dark color, orangey, bit of red color as well. So depending on what kind of medication or food that you've been taking, so it can also alter your urine color. Okay, there are the rare conditions that can cause red colored urine. We call it hemoglobinuria. Hemoglobinuria means that you got red cells, red blood cells break down that lead to basically you got hemolysis of the red cells that make your hemoglobin basically being excreted in the urine. So because hemoglobin is red colored, so it can cause red urine as well. Okay, so those are one of a few things that quite rare in rare condition that can cause red colored urine. Okay. Okay, now I'm just going to paste examination physical findings for this child in the chat box. You can read the chat box. Okay.
Okay, I will read. There is no anemia. She is apyrexia. There is no skin rash or bruising. There is no edema of the legs. There are no abdominal signs or joint abnormalities. Blood pressure is 124/80 millimeter mercury. There are no other signs.
Okay, so there's no pallor. Okay, there's no pallor. So what is the significance of saying that this child has no pallor? How, why this finding is significant?
In case we suspect for tumor,
anemia,
bleeding,
hemolysis.
Anemia. So you're basically talking about hemolysis or any major bleeding and so on. Okay. Apyrexia. So apyrexia, so no fever. So you basically
no infection.
Basically saying that this is no infection. So there's no skin bruising, no skin rash, no edema of the leg. So what does this signify?
Bleeding tendency.
So you kind of ruling out bleeding tendency, you're ruling out HSP, you're also ruling out ITP as well in this case, isn't it? Okay.
Yes.
Obviously, when you feel the abdomen, there's no sign of abdomen pain, there's no joint problem. So this definitely ruling out HSP as well, and ruling out any other condition. The BP 124/80, is it normal? Is it hypertensive?
Normal.
How do you know it's normal?
the ring.
How do you know it's normal?
Is it normal for kids?
Is it normal for kids? I don't know. I'm going to ask Adoya. Is it normal?
I think to us, we need to know his height and weight.
Okay, so correct. So you want to know the height and weights first. Okay. So by sorry. Ada orang dalam kereta ke apa ni? So you want to know the height and weight first. Is it me?
Ada.
Ada.
Okay.
So you want to it's still happening, eh? Hello?
Okay, dah.
All right. Okay.
So you want to know the height and weight so that you can come up with the centile chart. So once you know the centile chart, then you can use the BP centile chart to chart this blood pressure. So 124/80. So it's probably slightly high for a six years old child, kan? But I'm not so sure because you need to plot you need to know the height and weight first. By doing that, then you know whether this is 95th centile or 99th centile of the BP centile chart. So it's very important to know the height and weight. Okay. Normally for pediatrician ataupun pediatric nephrologist, they use orang kata rule of thumb lah, generalized. Kalau BP dia above 130 over 90, mana dia punya systolic above 130, systolic diastolic above 90, normally it is hypertension. In that case, then you probably want to treat the child. So it depends on the clinical judgment. So if you got a child like this, 124/80, kalau dia punya BP centile chart dia probably about 95 centile. However, the child has renal injury and renal injury or deranged renal profile, then you probably want to control that BP with a bit of medication. So you might want to use amlodipine or captopril to control the blood pressures. In an acute setting, if you think that the child has overloaded with fluids or odometers, then you probably want to give diuretics medication, try to get rid of excess fluids to reduce the BP. Okay, is it okay? Yeah.
Okay.
Pada pukul 3 dah ada lagi ayam berkokok. Okay. Okay, so those are the examination point of view. Okay, now I'm going to ask you for the question. Okay, so in this case, Farah is 6 years old. We know that Farah has hematuria. She has no dysuria. She has no frequency. She has no abdominal pain. She has no history of trauma, and her examination is basically quite normal with no joint problem, no abdominal tenderness, and so on. What investigation you would like to do? What is the baseline investigation you would like to do?
Baseline investigation, urinalysis.
Okay, you want to do urinalysis. So for what reason?
To confirm the presence of red blood cell. Is it because of red blood cell or just other cause of red color? Red color caused by other things.
So basically, you want to know that the blood, the red color of the urine is due to red cells, isn't it?
Yes.
Okay. So urine analysis. Okay, what else you want to do? So what else you want to look in the urine analysis?
Protein,
red cell cast.
Okay, you want to look in kalau the protein, okay.
Nitrate.
So you want to see the nitrate and
Nitrate
and leukocyte, isn't it?
Leukocyte.
Okay, so if it negative, nitrate and leukocyte is unlikely to be UTI. Okay, so the most important thing in this case is you want to see whether any red cells in the urine. Okay, and then what else you want to do with the urine?
Urine culture and
culture.
So you want to sample culture, same as for UTI as well. So you want to rule out UTI. Okay, what else you want to do with the urine?
What else, Zati?
What about 24-hour urinary reporting?
For what? Nak rule out apa?
Proteinuria. Nephrotic syndrome.
So basically, if your differential including nephrotic syndrome, then you can send urine PCR and protein creatinine ratio as well, or urinary 24 hours, urinary protein for 24 hours. Okay. What else you want to do with the urine?
Urine calcium to rule out if any calculus.
Cyanosis.
Okay, you can do that. Okay, obviously it's not that it's not that common in children to have urine calculi anyway. So basically what I'm looking for is you basically want to do urine microscopy to look for red cell cast. Okay. So if there is presence of red cell cast, meaning that this is
glomerular.
Okay, so it's a nephritis ataupun it's a glomerular punya origin of the condition. Okay. So what else? What other investigation you want to do?
Investigation, full blood count to look for evidence of infection, anemia, and the disease progress. And then renal profile to identify any complication.
Okay.
Acute kidney injury, and also urea and electrolyte level.
Okay.
And
Okay. Fine.
then
Okay. So I'm just going to share you the result of the blood test. Okay, so this is the result of the blood test.
okay. White cell count is elevated.
Is it elevated?
White cell count
Normal
range.
No. Normal range.
Sorry.
Normal.
Urea increase.
Urea increase. Creatinine is.
Okay. Let's go bit by bit. So the full blood count. So the child is not anemic as per clinical finding. So the HB is normal 11.7, which is fine. Slightly on the low side, but that's okay. White cell is within the normal range. The platelets. Why is important to know the platelet level?
Look for any bleeding tendency.
Bleeding tendency.
Yeah. So you basically the normal platelets, you are ruling out ITP, isn't it?
ITP.
So the sodium is okay, the potassium is okay, the urea and creatinine is high.
Urea is a bit high. It is high.
See? So it's both of them are high. So by definition, you can put this possible as acute kidney injury. Okay. And then they put in here as well LFTs. Why is it important to know LFTs? Why is it important to know the LFTs?
Coagulation and coagulopathy.
Yeah. You probably right. To a certain extent, LFT is part of the clotting coagulation profile.
What about albumin?
Yes.
Any massive loss of albumin.
Yes, basically you want to know the albumin is normal, isn't it? So if albumin is normal, then it's not you're not dealing with nephrotic syndrome. As simple as that. Okay. The previous 2 years ago, there's one student asked me, is it possible to have nephrotic syndrome with a normal albumin?
Yes.
Yes. Is it normal? Is it possible to have albumin? To have nephrotic syndrome with normal albumin? Yes. Yes.
Yes.
Raise your hands. Yes.
Yeah.
Okay.
It
So,
can
okay.
be.
So what is the definition of nephrotic syndrome?
Defined by presence of edema,
Edema,
proteinuria,
proteinuria,
hypoalbuminemia.
hypoalbuminemia. Okay. So if you have normal albumin, then it's not nephrotic syndrome. Okay, so you need to have three, at least three. So ascites or edema plus proteinuria plus hypoalbuminemia. Okay, you can have nephrotic syndrome in remission. So meaning that you got normal albumin, then you are in remission. Okay, but you cannot diagnose nephrotic syndrome if you have normal albumin. Okay, you can have normal albumin in nephrotic syndrome, but the criteria is in remission. Then that's fine. But if you want to diagnose earlier on as nephrotic syndrome, you need to have low albumin with edema with proteinuria. Okay, if you got normal albumin with ascites with proteinuria, then that's not nephrotic syndrome. Okay. Okay. Okay, then urine deficit dia ada blood 4+, ada protein, ada leukocyte, there's no nitrates. So, how do you conclude the urine dipstick? What is your impression? What is the conclusion of the urine dipstick? Oi, ada lagi ni ayam tu. Macam mana Saura? Macam mana urine dipstick ni? Okay.
Obviously there's a leaking.
Because blood is 4+.
So obviously there is nephritis, is it?
Yes.
Yes.
So you know this child had got nephritis. You agree with me? This is nephritis.
Yes.
Why is it nephritis?
Protein.
Because presence of blood and protein.
Because you got protein and you got blood in there, isn't it? Okay. So what about the nitrate and also the leukocyte? So there's leukocyte 1+ there. So is it infection? Is it UTI?
No. Really, nitrate is normal.
No nitrates.
Fine. So if you got nephritis, you got leaking of the blood vessels. So you sometimes you suspect you will expect some leukocyte. So not as many as blood, but some, probably a trace of leukocyte or 1+ of leukocyte. But you won't expect 2+ or 3+, because leukocyte is quite a big structure to cross the, even though you got leaky vessels, but it's still quite a big structure to pass through the basement membrane anyway. Okay, and then the microscopy showing the red cells, also showing the red blood cells cast as well. So this is big evidence to say that this child has nephritis. Okay, now I'm going to stop the sharing screen there. Then I'm going to ask you further questions. So what is the further investigation you would like to do? Apa lagi benda lain, test lain nak buat?
Anti-streptolysin O titer.
So you want to do ASOT, okay? Okay, what else you want to do?
Complement C3, C4 level.
Okay, you want to do the C3, C4, okay? What else?
Throat swab.
Okay, throat swab, okay. Okay.
Then for radiography, kidney, ureter, bladder, X-ray.
You want to do X-ray,
KUB.
Okay. Okay, fine. Let's go back. So you want to do ASOT titer, isn't it? Okay. So what do you expect in ASOT titer?
If it is due to streptococcal infection, it will be positive. That is more than 200.
Okay. So if it come back negative, if we come back negative, let's say SOT the normal. So what will be your conclusion from that?
So we suspect dia non-streptococcus atau non-infectious punya nephritis.
Okay, so for example, apa non-infectious nephritis?
SLE.
SLE.
Okay, so if that is the case, then what else you want to do?
Biopsy.
No, before biopsy lah.
ANA complement.
What to do anti-nuclear antibodies, isn't it?
Anti-nuclear antibody.
Okay, fine. Okay, let's say anti-nuclear antibody is negative as well. So what kind of nephritis it is?
Post-streptococcal.
Well, okay. If I say SOT negative, ANA pun negative juga. But the urine is very suggestive of nephritis. Maknanya urine dia memang ada blood, ada protein. Dia punya renal profile dia macam saya tadi lah, slightly raised urea, slightly raised creatinine and all. So it's just the SOT and also ANA negative. So what will you be thinking of the cause of glomerulonephritis?
HSP?
HSP?
HSP hypersensitivity vasculitis. Wegener granulomatosis.
Oh, okay. Ini kira dah level dewa belajar mana. Okay. So what I'm saying is, you can have normal ASOT in post-streptococcal glomerulonephritis. Okay. So it does not mean that negative ASOT is not post-strep. It could still be post-strep. Because why? Because the child has URTI symptoms 2 weeks ago. Okay, so because of the history of that, so you still treat this as post-strep infection anyway. Okay. Cuma if the SOT is negative, what you can do is you can repeat again in 2 weeks time to see is it any raise of the titer, because sometimes you can have a lagging raise of the titer. So maybe masa when you do it at that time, the SOT probably still quite low. But then 2 weeks after that, you can see a bit of raise of the SOT titer. So if it's negative initially, repeat again after 2 weeks to see the levels. Is it going up or not? Okay, that's one thing. The second thing is you also requested throat swab as well. Okay, so if the throat swab positive, then you can say this is post-streptococcal infection glomerulonephritis. Okay, but the history is already suggesting that there is URTI symptom. Most likely this child has glomerulonephritis post-streptococcal infection anyway. Okay.
Doctor, if throat swab is positive, is ASOT still needed?
No, not really. You don't need that. You can do either two. So you can do throat swab or ASOT. So if the throat swab negative, then so if the ASOT negative, throat swab positive, then that's enough. It is a post-strep infection. You don't need both. But remember, about 10% of post-streptococcal glomerulonephritis, but 10% of them has negative throat swab and also negative ASOT.
Okay.
Given that the ANA is negative as well. Okay. Cuma when you come to when you come to textbooks, then obviously you expect ASOT will be raised as well, throat swab will be positive, and then you have the history to suggest URTI symptoms. So those are the positive factors to lead to streptococcal glomerulonephritis. Cuma when you come to the clinical, when you work with a patient, sometimes you don't know what is the cause. There is no evidence to suggest streptococcal. If you do swab negative, SOT pun negative, ENA negative. So sometimes you don't know what caused that. So in that particular case, you put down this patient as post-streptococcal glomerulonephritis anyway. So, but it's about 10 to 50% of them have negative result for glomerulonephritis. So that's the main thing. Tapi textbook you expect SOT raise and also tooth swab
positive.
For in nephritis, glomerulonephritis.
Doctor, what about the complement C3, C4 level?
Yes.
So, kita kena buat, do we still?
Well, you still need to do that.
Oh, okay.
Okay. Because those are the things that you probably want to ensure that you're not missing the SLEs, you're not missing the nephritic kind of mixtures there. So you still do the C3, C4 because sometimes it could be other autoimmune condition that cause that as well. Because ENA negative is only ruling out SLE. Okay. However, it does not rule out other conditions as well. So there's plenty more autoimmune condition that cause vasculitis. So ENA negative, you probably can say this is not likely to be SLE, but you're not ruling out any other rheumatological condition that can cause vasculitis as well. So there's plenty more condition with negative ENA vasculitis. But I don't think that we should go through that at your stage anyway. Okay, so you do the X-ray KUB for kidney stone, but how sensitive is X-ray KUB to detect kidney stone?
Not so sensitive.
Not so sensitive, isn't it? It's not that.
Ultrasound. Yes,
so ultrasound probably is a better modulation to use to detect ultrasound. But if you suspect a kidney stone in a child and you do renal ultrasound scan, what will be the appearance of the ultrasound that you expect?
Dilatation of upper tract.
Okay, so you're talking about dilatation of the ureter mainly. Okay, so you're talking about ureter. Okay.
Doctor, can hydronephrosis be viewed on ultrasound?
Yes, hydronephrosis can be seen on ultrasound. Mana grade 1 to grade 4, grade 4 you can see on. So the issue is the size of the ureter is based on the age n. Okay, so a 3-year-old ureter size not the same as the 6-year-old ureter size, not the same as 20-year-old ureter size. So same as kidney as well. The kidney size for 3-year-old compared to 6-year-old compared to 20-year-old is not the same. Okay, so it's so difficult sometimes to comment on the size of internal organ in a child because they don't really have a set limit. Mana kalau 3-year-old kena 5 cm, kalau 6-year-old kena 8 cm of kidney kan. There's no set size for a child. Okay, because the size of the internal organ depend on the size of the child itself. Kalau if you got a 6-year-old weigh 30 kilogram compared to a 6-year-old weight about 18 kilograms, so the size of the internal organ will be different as well. Okay, so that's why they use a rule called it relative size. So they scan the kidney, they scan the liver, they scan the spleen, and then adalah dia punya formula calculation dia. By comparing those size, then they come up with a number that is relatively suitable for that particular child. So kalau a 6-year-old kidney size compared to another 6-year-old kidney size is not the same because it depends on the size of the child. Obviously, in adult, we tend to use a set size. Mana adult ni at least maybe you and me, our kidney size is probably about probably the noise. Okay, so I'm going to show you the further investigation results. I need to share the screen again. So this is the first investigation results. So the throat swab that we will do. So theoretically, you expect a positive throat swab for strep or staph species. The ASOT in glomerulonephritis, you expect raised ASOT. The C3 will be reduced, C4 will be normal. ESR can be slightly high in glomerulonephritis. ANA normally negative unless if you suspect SLE, then it could be positive. Okay, abdominal X-ray is not really helpful to rule out renal calculi in children, but we normally use renal ultrasound scan anyway. Okay, so if the child got glomerulonephritis, if you do renal ultrasounds, what kind of appearance of the renal ultrasound that you will expect? Let's say this child got AGN, PSGN. So and then you do a renal ultrasound. What do you expect in the finding of the renal ultrasound?
Kidney enlarged.
Okay. Enlarged kidney. But I mentioned to you that you don't know whether the kidney will be enlarged or not because of the size. So what is the thing that you might see? Sorry? Okay, so if the child got glomerulonephritis basically it will affect the renal parenchyma, kan? Okay, the kidney is slightly swollen. So when you do ultrasound scan, you will see we call it brightness. Dia punya nampak macam very bright. Ataupun we call it high echo density, increased echo density when they do the ultrasound scan. So those are suggestive of possible parenchyma disease. Could be grade 1 or grade 2 depending on how swollen the kidney are. Okay. Okay. So in this case, okay, the most likely diagnosis is the prostate-cytocol glomerulonephritis. The reason for that is because the history is suggestive of URTI symptom 1 to 2 weeks before the start of the hematuria. Okay, and normally the child might have oliguria, maknanya dia kencing sikit, and bit of renal failure. Okay, and in this case it's quite mild, and obviously the red cell cast in the microscopy, if there is presence, it indicates there is renal involvement. Okay, so theoretically, once you got glomerulonephritis, your blood supply to the kidney slightly reduced because you got inflamed kidney. So sometimes the blood supply to the kidney is reduced. So because it's reduced blood supply to the kidney. So sometimes you got reduced filtration rates of the blood supply. So meaning that you will produce less urine. So that's why they become slightly oligouric. But most of the time that we see children with posterior AGN ni, selalunya dia punya kencing dia biasa-biasa je, tak adalah reduce sangat. So normally we don't in terms of their urine output anyway. But still, if you suspect any kidney problems, it's always good to measure input-output, mana strict input-output. Berapa banyak dia minum, berapa banyak dia makan, dan berapa banyak dia kencing keluar, ataupun kalau dia ada loose stool, you measure everything. Because you want to make sure that you really want to make sure that the child is not overloaded or too dry. Okay, sometimes you need to be very sure where is this blood coming from. Is it really from the urine, or is it from the vagina, or is it from the rectum? Okay. Okay, a 6 years old, if if a child, if this child, 6 years old, have bleeding from the vagina, so what you will call this? And they are the bleeding PV bleed. So what will you call this? Period.
Precocious puberty.
Okay, so if it's period, then you need to think about precocious puberty as I don't know, siapa cakap ni? So you need to think about precocious puberty, okay? If it coming from the rectum,
Abuse.
okay, so it could be due
Trauma.
to constipation. Mainly it's constipation lah, mainly it's constipation, or it could be abuse or physical abuse or trauma ke apa. So the two things that if the bleeding coming from the rectum or from the vagina, they need to think about abuse as well, because we are living in a sick society. Our society is a sick society that sexual abuse and physical abuse can happen to any age. Tak kisahlah umur sehari ke, umur 16 tahun ke, it can happen to anybody, and you always need to think in your mind that it could be a form of abuse as well. Obviously the form of abuse, it should be more than that lah. Maknanya bukan setakat ada bleeding je. Maybe bruises kalau macam in the girls, you want to see is the bruises around the majora, labia or minor labia and so on. In the boys, if they've been sodomized, then you want to see is it any sign of another physical abuse as well. Maybe abuse dekat thighs ke, bruising on the thighs ke, or somewhere else in the body, because it's not a straightforward thing to diagnose abuse. Food, as I mentioned before, beetroots also can lead to red urine. Hemoglobinuria due to hemolysis also can cause red urine as well. And obviously, in this case, hemoglobinuria, there's no red cells when you do on the microscopy. It's just the hemoglobin that gives you the color of the red urine. The other thing that I would like to mention is about enuresis. Okay. So enuresis maknanya bedwetting lah. Okay, bedwetting. You also need to think about possible abuse as well. So if somebody coming to you with history of hematuria, but at the same time the child also has history of bedwetting. Bedwetting, there's two types of bedwetting. There is primary bedwetting and also secondary bedwetting. Primary bedwetting means that the child has never been dry at night all their life. Itu adalah primary bedwetting. Maknanya kalau umur dia sekarang 8 tahun tu memang dia tak pernah dry pun at night. Always have bedwetting at night. Okay. Secondary bedwetting means that the child has achieved dryness day and night at least for 6 months before they start to wet again. So those are the difference between the primary and secondary bedwetting. Okay, so the secondary bedwetting, you need to consider physical abuse or sexual abuse for secondary bedwetting. Kalau primary, you don't. It's rarely abuse that cause the primary bedwetting. Any question about that? No, eh? Okay. This is the causes of hematuria. UTI is the top of the list. Nephritis, especially post-strep AGN, henoch-squalene purpura, IgA nephropathy, and nephrotic syndrome. Okay, henoch-squalene purpura is mainly clinical diagnosis. IgA nephropathy, you need a renal biopsy. Nephrotic syndrome, you don't need renal biopsy, but you need all investigation, urine PCR, 24-hour urine, LFTs, and so on. But about 1/5 ataupun 20% of hematuria can occur in nephrotic syndrome. And 20% of nephrotic syndrome can have hematuria. Trauma also can cause hematuria. Calculi, hematological disorder or bleeding disorder can cause that. And also anatomical causes. Tumor also can cause. So tumor of Williams tumor, so tumor of the kidney can cause hematuria or painless hematuria. Medication, factitious illness, and also recurrent Basically, you do everything first. Once everything is negative, then you put them as recurrent benign hematuria. Factitious illness is basically things that you made up. If you, I don't know whether you heard satu condition called Munchausen syndrome by proxy. Munchausen. M-A-U.
M-A-U.
Munchausen. M-A-U-C-H-E-N-S-E-N kot rasanya. Betul tak?
Munchausen syndrome.
Munchausen syndrome by proxy. So it's basically a psychological or psychiatric illness. Normally, the person will use a proxy to get attention. For example, I got a child. Sorry. For example, I have a psychiatric illness. I want to gain attention from somebody else. So I will use my child to get that attention. Soalnya medical doctor lah. So let's say my child has hematuria kan. So what I did was I asked my child to urinate in a bottle and I put probably mungkin letak darah ayam ke, darah kambing ke, darah lembu ke. Then I come to hospital, say that my child's been weighing blood in the urine. Okay. The way that you know this is if you remove the parents from the child is normal. Takkan ada blood in the urine. Once the parents look after the child, there will always be problems. When you examine the child looks normal, tak pernah ada problem, nothing else. The thing that you're suspicious. So when you remove the parents from their care, the child have no hematuria. Once the parents come back to their care, the child will have hematuria because they can put anything in the urine. They letaklah apa-apa, letaklah darah mana-mana. So those are the meaning of factitious illness is you made up the symptom. Faham? Okay, so basically year 3 we don't really go into treatment sangat, but I just let you know about the treatment in this case. So if you suspect glomerulonephritis, post-streptococcal infection, you give 10 days of oral penicillin for the condition. The penicillin is not for the glomerulonephritis; it's to eradicate streptococcal infection. Okay, it's not for the glomerulonephritis. Okay, because once you got glomerulonephritis, it will take some time to get better. But you give antibiotic just to get rid of the streptococcal infection. Normally, you restrict the child to about 1 to 1.5 liter per day, and then you advise the parents not to give too much salt in the diet. Kalau patient tu ada hypertension with evidence of overloaded fluids, then you give furosemide. Otherwise, you can control them with calcium channel blocker like captopril or amlodipine and so on to control the hypertension. Obviously, if there's heavy proteinuria and then the patient develop renal problem or renal function deteriorates, then you probably want to do a renal biopsy early on to make sure that you're not really missing anything else. If the child got hyperkalemia, then the child might need treatment in terms of dialysis and so on. Okay, if it's just a normal, typical glomerulonephritis, you just monitor the BP, you dip the urine every weekly and see what's the progress. Normally, the gross hematuria will settle down within 2 to 3 months. Either the microscopic hematuria might take some time to disappear. Sometimes it takes up to 18 months to 2 years for the microscopic hematuria to disappear, to resolve. PSGN can progress into nephrotic syndrome, and sometimes it can progress into chronic kidney failure as well. So, but it's quite rare anyway. Okay, so UTI, PSGN, PSP is quite common to cause hematuria, and PSGN is if you got it, it's quite a good prognosis. It basically resolve within 1 to 2 years anyway. without any big intervention. Okay, any question about this case? Any question? No? Dah sejam setengah. We need to go to another case. Okay, no question So we move to case 2, boleh?
Boleh.
Okay.
Right. So thank you, Safra. So who's going to lead the next case?
Me, Najwa.
Okay. Right.
Okay. Okay, we're going to proceed to the next case. Johan is an 18-month-old boy referred to the community pediatric clinic because he is not yet walking. He was born at 41 weeks gestation following an uneventful pregnancy. There was meconium staining of the amniotic fluid, but he cried immediately at birth and didn't need any resuscitation. He has been generally healthy apart from normal cough and colds, and he had chickenpox 6 months ago. His parents recall that he could roll over at about 4 months, sat up alone at 10 months, crawled from 3 months, and was able to bare walk on hands and feet and pull himself to standing from around 17 months. He can take a few steps holding onto furniture but cannot walk independently yet. He is able to scribble with a crayon with either hand and can slot pieces into a shape sorter toy. He uses lots of single words appropriately, understands simple instructions, feed himself with a spoon, and will also feed his teddy bear. The parents have no concerns about his vision or hearing. He attends nursery 3 days per week and is described by the nursery staff as a likable boy, although they have been concerned that he still doesn't walk. There is no family history of delayed walking. Johan's mother is an accountant and his father is an architect, and both are in their early 40s. They are hoping to have another child soon.
Okay, so I'll leave to Najwa to. So what other question you want to ask?
So for the chief complaint, we know that the main concern of the parents is because Johan still couldn't walk yet, and at 18 months old, not walking is the key developmental warning signs. So apart from the stated history, are there any other history that all of you want to ask?
Any other question you want to ask?
I think
Is there anyone in their family that also have the same developmental delay?
Okay. Next, I think any family history of consanguinity between his parents.
Okay.
Is there any events during labor that happened?
Is there any event during pregnancy?
So what kind of events during pregnancy that you want to clarify?
Maternal
infection.
Infection.
So
Infection.
What kind of infection that you are talking
Diabetes.
The
tortuous
infection.
Sorry?
The tortuous infection.
Okay, so you want to know about the torch infection. So torch is basically toxoplasma, rubella, apa tu, cytomegalovirus, herpes. That's it kan? Torch. Nah. Okay.
EBV.
So
Doctor, I have a question. Is Zika virus considered as torch too?
No. Zika is a new thing, so it's not in the torch. So torch is basically toxoplasma. Toxoplasma is very common in kitten. Okay, in kitten, not cat, kittens. Small baby cat. very common in baby cats. So if you are pregnant, okay, do not play with kitten. Okay, because you can contract toxoplasma. Basically, you can have cat or kitten. It's just that all of them need to be vaccinated if you want to play with that. Rubella, obviously, it's not common at the moment because all of us are getting MMR quite well. So, but rubella also can cause global developmental delay as well. So that's rubella. Cytomegalovirus can cause brain malformations, or sometimes it can cause neurological condition as well. And then the herpes simplex can also cause brain infection as well in babies. So it's very important to know about maternal TOSH screening if there is any TOSH screening. Okay. You also want to know in terms of events during labor. What kind of events during labor that you want to know?
Hypoxia. Okay,
you want to know any event that's suggestive of hypoxia. How do you know the child is hypoxic at delivery during labor?
Crying.
Okay, crying. What else? The main thing that if a child was hypoxic during labor, they might probably need resuscitation at birth. That's why in this particular case, it says that the child cried immediately after labor, not needing any resuscitation. So those are the key that this child delayed walking, likely not due to intrapartum or during deliveries. Okay, so this child this problem is not due to the delivery punya issues. Okay, what else you want to know? What other question you want to ask? So you're talking about family history. So there's if I say to you there's no other family history of delayed walking or any conditions. So what other question you want to ask?
Any history of seizure?
Okay, so I think there's no family history of seizure.
I want to ask about other children. They are having delay walking.
Okay, so there's not in this case they didn't mention
The
about
only
other
child.
children.
The only child.
So because they're planning to have another child. Okay. Okay, what else?
The usage of drugs and alcohol.
Ingestion of drugs, alcohol.
During pregnancy. During pregnancy.
During pregnancy.
Yes, antenatal.
Okay, fine. Okay. Okay.
Prematurity.
So I say, well, in this case, it's 41 weeks, isn't it?
The birth weight.
41 weeks is basically term baby, yeah.
Neonatal jaundice.
Neonatal jaundice.
Jaundice, I would say there is a jaundice, but not requiring any treatment.
Any trauma?
Okay, there's no trauma.
Childhood infection.
Yes, just a simple cold cough symptoms now and then, but nothing else.
Can we ask about syndromic features towards the parents?
Okay, that's right. Well, the parents won't know any syndromic features, but I'll give you the information later on. But it's just the question that you want to ask. Any other question you want to ask?
Doctor, the birth weight, is it possible to ask?
Okay, let's say the birth weight was 3.2.
We need to ask mode of delivery. Is it emergency?
It's a normal delivery. It's a normal vaginal delivery. Okay.
What about nutrition?
Nutrition there, just a normal nutrition. 18 months old, now weaning and eating food as a normal child. Maknanya still need to grind the food a bit, but mainly he's eating what we eat anyway.
Consanguineous marriage.
There's no, it's not, it's the non-consanguineous marriage. Okay, before that, either Najwa or Najwa want to pass the question to somebody else, it's okay. So what is your conclusion about his developmental milestones?
So from my perspective, I think this boy is generally having a gross motor developmental delay instead of other development.
So what do you call that?
Gross motor delay.
Okay, almost right, but what is the correct wording?
Global.
Not global. Global should be more than 2.
3.
So let's go back. Let's go to the gross motor. So what is his gross motor? So he said that he can roll over at 4 months, which is okay. Is it okay? 4 months roll over? Is it too late? Is it too early?
It's too early.
Too early. So any of you got children or any maybe ada adik yang kecil-kecil ya?
Tak ada.
So kesian bunyi. Bongsu ke?
Roll over at 4 months is normal.
6 months.
Yeah. So
roll over is 6 months.
So roll over can happen between 4 to 6 months. Okay, so that's okay. Set up alone at 10 months old. Is it delayed? Is it normal?
Normal.
So you have 6 months. You have sitting up with support, sitting up without support, and so sitting up with support at what age?
Sitting up with support.
6 months.
6 months.
Sit up without support. Mana you have two, and you have sitting up curve back and also straight back. So curve back at what age?
Curve back.
Mana sitting independently, mana sitting alone, but dia punya back dia curve, kan dia macam bongkok sikit kan. And then sitting up alone with a straight back. So you need to know those two, the difference between those two kan. Okay, so normally a child sitting up without support with the curve back about six months. By 8 to 9 they dah sit up with a straight back. Okay, so 10 months sit up alone, 10 months slightly late lah, slightly delayed. Okay, crawling at from 13 months. So crawling by 13 months, is it okay? Is it late? Is it normal?
Quite late.
Quite late.
So be 12 months.
12 months.
So you expect crawling should be before 12 months, maybe 9 to 10. And now bear walk on the hand. Mana if you hold his hand, he will bear walk. Bear walk ni maknanya bukan bear walk. Bear walk is dalam macam beruang lah.
On 4.
Okay, so slightly ataxic punya gait. So a child should be able to do this by 11 to 12 months. And then he's only be able to pull himself up to stand from around 17 months. So that's quite late as well, kan?
Yes.
Pull up to stand ni what age? Dalam pitch protocol
9 months.
9
months. Should be 9 months, kan? So this child by definition, obviously you need to look other things as well. Mana fine motor dia macam mana, dia punya speech and language macam mana, dia punya social skill macam mana. Social skill dia apa ni, feeding himself with spoon, feed the teddy bears, hearing no concern about hearing, speaking single words, scribble either hand, okay, not too bad. So why is it important to know scribbling appropriately? Sorry, scribbling with either hand. Why is it important? Scribbling with either hand.
Hand preference. Hand preference.
Hand preference. What age do you develop hand preference?
18 months. 18
months.
18 months kan?
Yes.
So this child is probably slightly delayed in terms of their hand preference kan? If you develop hand preference before 18 months, what will be your concern? Cerebral palsy.
Yes.
Cerebral palsy. Okay. So the reason that in cerebral palsy you got a bit of weaknesses on one side, so you'll be using the one that not affected.
Yes.
So those are cerebral palsy. Okay. So the way that I summarize this developmental milestone is, I would say this child has isolated gross motor delay. Okay, so those are the main things. So one domain affected, we call it isolated. You got more than one, mana 2 and above, it's going to be
global
delay.
Developmental delay. Okay, so everyone got it. Okay, now I'm going to share you the examination punya finding. Right, can you see?
Examination.
Okay, sorry. This is the examination findings. So what can you make up from this examination finding? So it looks well, enjoying interacting with you. So socially he looks okay. It's not dysmorphic. The most important one is not dysmorphic. If your weight there 10.8, which is 25th centile. If your height there 25th centile. If your head circumference is 50th centile. So that's quite common in children that might have a bit of kepala besar ataupun besar kepala compared to the weight and to the height. So it's not, maknanya tak adalah big differences between the weight and height centile compared to the head circumference centile. Unless kalau dia punya head circumference dia, the head size is quite big different. Maknanya maybe depends centile dia probably about 95th centile ke 99th centile, then there's a big difference. But 25th to 50th centile is not a big difference anyway. So that's quite normal to have this kind of measurements. And then CVS, respiratory, abdominal examination are normal. The spine is normal, the joint is normal, and then there's no neurocutaneous lesion or birthmarks. Neurological examination, cranial nerve normal, normal posture, normal tone, normal power, normal reflexes on the upper and lower limb. Tidak ada tremor. Tremor it could be a sign of CP as well.
CP.
And then when you help him to stand, he will hold onto one side on the lower table. Dia akan pegang satu side, and then he will take a few steps while holding with both hands. So 18 months old, still needing help to take a step. Okay, so this is from the examination. This child shows that he has associated gross motor delay. Okay, from the examination and from the history, okay, what would be your differential diagnosis?
I would suggest Duchenne muscular dystrophy.
So from the examination and the history, why do you think this is Duchenne?
Because there's no tremor and then the posture tone tak bawah system. So
you say there's no tremors, so it's not Duchenne. So why do you think this is Duchenne? What is in the history that's suggestive of Duchenne?
can only take few steps holding on furniture, position of his walk, and there's no other things that suggest like CP or any other.
So basically the history and also the examination, mana history dia not sensitive of CP because dia punya delivery dia normal, mana dia tak perlukan not needing ventilation, not needing intubation and so on. So no normal delivery, not needing any resuscitation at birth. Okay, it's not showing any sign of hand preference yet, even 18 months. So those are also negative signs for CP. Dia punya examination dia normal, maknanya tone dia normal, posture dia normal, reflexes dia normal. So those are unlikely to be CP. Okay, so you basically rule out CP. Okay, what else? So with the history, you be thinking about CP as well, kan? Cuma the history dia, examination dia does not say suggestive of CP. Okay, so that's one of your diagnosis been ruled out. Any other differential that you want to rule out? So now you're talking about Duchenne, but is there anything that in the history and the examination that's suggestive for Duchenne?
Delayed walking. So
apart from delayed walking, that's it, kan?
Yes.
Any other sign or history that suggestive of Duchenne? Apart from delayed walking?
No.
No.
Swollen calf.
No, nothing, kan? Nothing.
Yes.
Yes.
Okay. But I say to you, there is one information that is very important to suggest Duchenne. Can you find that information? Orang dah senyap, orang dah tidur. Orang boleh?
Only emails.
Sorry?
Only in males.
Yes.
X-linked.
Oh.
Yes.
X-linked.
It's a boy. It's a boy. This is a boy. Okay? This is a boy. So those are the two things, delayed walking and boy. It's a very, very important thing you want to pick up, that this is likely to be Duchenne muscular dystrophy. Okay, so CP and Duchenne. Okay, anything else that you want to rule out? Anything else that could be in your differential diagnosis? Could it be Down syndrome?
Down syndrome.
Yes.
Okay. So you need to think about Down syndrome. However, as you mentioned, the child is not syndromic. Okay. The cardiovascular is normal. So there's no murmurs. And then you're talking about tone here. Normally in Down syndrome, you have hypotonia. This child has normal tone. So yes, you can think about Down syndrome, but the history, the examination doesn't look like Down syndrome. Okay. Okay. So the way that you need to look into this question is it cardiovascular? Sorry, is it central nervous system category? Is it neuromuscular junction? Is it muscular condition, or is it musculoskeletal conditions? Okay. For example, if you're talking about CNS, it could be meningitis, CP, and so on. So those are the things. You're talking about possible muscular condition, which is Duchenne muscular condition. You're talking about musculoskeletal, it could be bone problem ataupun dia punya hips problem.
Joint.
Sometimes you can have, we call it congenital hips dislocations. So those could also lead to delayed walking as well. If you're talking about a neuromuscular junction, you're talking about botulism, or you're talking about myasthenia gravis. Those are the differential diagnosis for neuromuscular junction. But if you're talking about myasthenia gravis, normally we call it wax and wane. Maknanya early morning the child looks okay, by evening time they got weaker. Those are the signs. Tapi in the history does not really suggest any sign of myasthenia gravis at all. Okay, so by doing that, you know that I'm dealing with Duchenne muscular dystrophy. Definitely, This is not CP. I've not seen any sign to suggest the child is dysmorphic to suggest any Down syndrome. I don't think this is a congenital
infection.
Congenital infection could be as well, but obviously you need to look for sign of kalau macam toxemia and so on. Normally you expect the child have microcephaly because the infection already happened intracranial. Sorry, before delivery, masa antenatal. If you got meningitis, normally it will affect your neurological examination. Maknanya you got posture abnormal, tone abnormal, and so on. But this child has nothing else apart from the delayed walking. Apart from voice, the rest of the organization are normal. So you need to think about Duchenne at this moment. Okay. And then, okay, I need to stop the sharing first. I need to okay. Then siapa ni? Najwa kan? Najwa. Okay. So the question I wanted to ask is, what investigation you would like to do in this case? Even though you're quite confident that this likely to be Duchenne, obviously you want to do a test for Duchenne, but at the same time, is there any other test you want to do?
Muscle biopsy, any serum creatine phosphokinase, blood investigation.
Okay, you want to do blood investigation first, then? Okay, so you want to do CK?
CK.
So do this CK. So in Duchenne, you expect CK will be high, isn't it?
Yes.
So why in Duchenne you got high CK?
The dystrophy of the muscles.
Breakdown of the muscle.
You basically in Duchenne you got a condition where your muscles is consistently your muscle is persistently being breaking down every day, every hours, every minute, every seconds. Your muscles is being breaking down. So all the products of breaking down of muscles will lead to the high levels of the toxin in your body. So one of the enzyme ataupun one of the chemicals in your muscles that will be elevated because you'll be breaking down is your CK. So CK is mainly in your muscles because you're breaking down. Then your blood serum CK will be high as well because of that. Okay. So normally you expect a CK probably about 20,000, 30,000 because your muscles have been breaking down constantly. Okay. So any other blood test you want to do?
Any FBC? FBC in order to suggest any infection?
Okay. Obviously you can do a full blood count, but it's probably not really helpful to establish diagnosis. Because this child is not walking, so you probably expect that there's not much in terms of infection at this stage. But practically you do everything. You do full blood count as well, just for baseline. But it's not going to help you for reaching the diagnosis. Any other investigation you want to do? Tanya orang lain pula. Tanya apa? Zati lah.
Electromyography.
You blood test lo.
Oh.
So anything with delayed milestones, you need to think about hypothyroidism. It always send TFTs for regardless whether gross motor delay ke, fine motor delay ke, apa-apa delay lah. You just send TFT because hypothyroidism can cause delayed learning difficulties ke, slow learner ke, or global delay and so on. So you just send for TFTs.
Okay.
Okay. And then you just want to rule out anything else. So sometimes you just send karyotyping. Okay, karyotyping, mana just check for
Mutation.
chromosome. Check for chromosome. Kalau Down syndrome, then it's Down syndrome. Kalau anything else, remember karyotyping is only looking at the numbers of chromosomes. Okay, it does not look into the genetics. Kalau ada mutation ke, kalau ada deletion ke, addition and so on, it does not look into that. It's just going to make sure that the child has 46 chromosome, boy or girls. That's it. So, kalau ada less than 46, then abnormal. Kalau ada more than 46, is abnormal as well. Okay, so karyotyping is only looking at the numbers of chromosome and also gender as well. Okay, if you want to do further investigation, mana want to do genetic studies, then you need to send for microarray. Microarray looking for next sequencing generation. Mana they look into the every single allele, every single genetic component of the chromosomes. So those are the further investigation you want to do. If you suspect this could be syndrome yang pelik-pelik lah, maybe you're talking about Fragile X syndrome ke, you're talking about other syndrome yang lead to the delayed development. Okay, so those are the things that you probably want to do. Probably just want to make sure that this is not electrolyte problems like sometimes low potassium and also low calcium also can cause stiffening of the muscles, stiffening of the joint. So sometimes they cannot walk because of the low potassium and low calcium. So those are the things that you probably need to check as well as part of your baseline investigations. Then, what is the further investigation you want to do? So you're talking about EMG. EMG is basically looking at the electrical activities in the muscles. And
Doctor, at this stage, should we send for visual and hearing assessment as well?
You definitely can, but it's probably not going to make much difference in terms of diagnosis, because I suppose the child has no problem with the vision, the child has no problem with the hearing, but you can always complete the investigation by just doing that anyway, for the sake of completion of investigation. So in terms of whether it will give more information to diagnose the disease is probably not helpful.
Very important.
Yes. Okay. Okay. So if you suspect more than that, if you suspect it could be neurological condition or CNS condition, then you can request for MRI brain or CT brain, or sometimes you can go for MRI brain, MRI spine as well, just to see is anything else that could lead to this problems. But apart from that, I think the most important one in this case is CK. CK is the most important one to do at the moment, because it could be the only thing that will lead to diagnosis.
Okay.
Okay, so I'm just going to share my slide again. So basically, the most important investigation here is CK. And then the high CK is normally almost 2 seconds.
And it shows you the progressive
Patient sikit kan?
in other areas of development.
Ada hantar balik ke Mari saya kena datang meeting ke apa? Okey, tak apa, okey. Okey, ya, boleh. Okey, okey, you can saya boleh tengok saya. Okay, sorry about that. So basically, that CK is almost diagnostic in this case. However, you still want to do the gold standard for Duchenne is still you want to do biopsy anyway. So you still want to do the muscle biopsy to confirm diagnosis. But if you got high CK, it's almost pathognomonic for Duchenne, especially in voice. And we know that Duchenne is X-linked recessive. So kalau parents nak ada another child, then they need to have we refer them for genetic counselling, just in case because if another child is a boy, then there is likely that the child will also develop Duchenne as well. Because the chances is about 1 to 4,000 of male birth anyway. And we know that the progress is a progressive muscle weakness. So the child might be able to walk initially, and then after probably 2 to 3 years, they start to tumbling around, start to falling around, and then by teenagers they might be chair bound, and then probably by 20 years, 20 to 30 age of 30, they will probably wheelchair needing an IV and so on. So, and some of them might have a bit of learning difficulties as well, and also might have social or speech problems. And so delayed walking is quite common. However, most of them are just a normal delayed walking. Only about 3 to 5% has problems, and then tapi most of them will be neurological conditions. Only about 1%, about 1 to 2% have a muscular dystrophy. So even you have an 18-month-old child that's still not walking, it could still be possibly, most likely, it's a normal leg walker. By 2 years old, by 2.5, they're probably walking as usual. Okay, and then this is example of differential diagnosis. So if you're talking about generalized developmental delay, it could be Fragile X syndrome, it could be Down syndrome. For neuromuscular, it could be CP. Also, it could be muscular dystrophy as well. Musculoskeletal, talking about congenital dislocation of the hips. And then most of them are normal leg walker. Okay, however, if somebody not walking by 18 months, you should always be precautious. You should always refer them for further investigation. Okay, because you want to, if this is Duchenne, then you probably want to treat with with steroids or tolerance just to slowing the progress of the disease. So you know, steroid can slow down the progress of the muscle breakdown, or tolerance can help in terms of improvement of the muscles function. Okay, so as I say, failure to walk by 18 months is a warning sign. You need to refer them, and if this is a boy, then you want to rule out a Duchenne. So basically, you want to do a CK. If the CK is high, then you proceed with a biopsy of the muscles.
Doctor,
okay.
For Duchenne, if the patient got proper treatment, is the prognosis better? I mean, longer.
You basically can prolong their life. Okay, so by starting steroid early, then you're hoping that you expect the child probably can progress into their 30s or 40s. Okay, the thing with Duchenne is they don't die from Duchenne. They die from the complication of Duchenne, which is the chest condition. Okay, because most of them will have orthostatic pneumonia or recurrent chest infection because Duchenne will affect not just their mobility, but also they affect their pulmonary function as well, the chest function. So they might not be able to breathe normally, so they might need non-invasive ventilation like a non-invasive CPAP and so on. So those are the issue with Duchenne. They don't die from Duchenne, they die from the complication of Duchenne, which is mainly the recurrent chest infection, and sometimes they might have a cardiac complication as well.
Doctor, related to this case, is there any significant to the history of chickenpox 6 months ago?
Okay, so that's the point. Chickenpox is probably not that significant. Okay, chickenpox. If you got chickenpox, the complication of chickenpox normally happen almost acutely, especially varicella ataxia or varicella cerebralitis. So it's normally happen soon. Once you got chickenpox, you will develop ataxia within 1 to 2 weeks after that. It's rarely happen after 6 months, unless if you have measles. Measles, complication of measles is SSPE, which is subsclerosing panencephalitis. The SSPE can happen anytime in your life. So if you got measles at 6 months old, the SSPE can happen at 10 months, 10 years old, 20 years old, 40 years old, 60 years old. So you can't predict the complication of measles. So for chickenpox, it's not that significant. I think in this case, I think they just want to give you the red herring here, give you some information, but it's not really significant in this case.
All right.
Doctor, children with hypothyroidism will have the same presentation as adult ke tak?
Okay, children with hypothyroidism tend to have more than this lah. Maknanya they don't only have delayed walking, they will also have hypotonia. They might have fine motor problem as well. Socially and also speech problem also has some problem as well. So it's not just delayed walking. They will have more than that. But it's always good to have thyroid function status as part of your investigation, because if it's normal, then it's normal. If it's abnormal, then you need to treat the hypothyroidism.
All right.
Anything? Another question you want to ask?
Doctor, have you
Doctor,
seen Duchenne case before?
Sorry.
Have you seen Duchenne case before?
I've seen Duchenne case back in the UK, but in Malaysia I've not seen one yet.
Doctor, has anybody ever survived far longer than 30 years old?
What?
Has anybody with Duchenne ever survived longer than 30 years old?
Well, it's possible. Because
so there,
what do you need? What do you need in Duchenne is you need a good treatment. Maknanya being on medication like either steroid or accelerants. The most important thing about Duchenne is plenty. You need to be persistent with physiotherapy. A lot of physios to keep your chest, your pulmonary function well. Make sure you are mobile all the time. So those are the main thing about Duchenne. So if you have good physiotherapy session, good physiotherapy regimen, you obviously can maintain your life more than 30 years old. I've seen because we are doing pediatrics, so normally you don't really see age more than 20. So the most that I've seen in the UK is 20 years old. Then they go to the adult medicine. So that also meaning that we pediatric we don't really see them anymore. We pass the care to the adult people. So I'm sure that some of them might pass 30 years old, 40 years old, but they must have a good regime in terms of physiotherapy, making sure their chest is well developed, making sure their chest function is good as well. A lot of physios, a lot of therapy. The most important thing is you do physio in terms of kita panggil hydrotherapy physio kan. A lot of swimming will involve your lung function and also your limbs movement as well. So most of them doing a lot of swimming session as part of their physiotherapy session. Okay. All right, any other question you want to ask?
Doctor, one more. Nak tanya. Does Duchenne only if the person have delayed walking, or if that children difficult to getting up from sitting, can we also like diagnose the patient having Duchenne?
Well, as I say, you need to go through investigation as well. Kalau dia cuma ada proximal myopathy, so if you can't stand up from squatting position or from the sitting position up, then you got proximal myopathy kan. Proximal myopathy, or in other words, you got apa nama sains tu? What signs you got it? Gower signs. Sorry, yeah, you got Gower signs. So Gower sign is a proximal myopathy signs. So so what you need to think first is you need to do the CK first. Okay. If the CK is normal, then it's unlikely to be muscular dystrophy. It could be something else. Okay,
thank you.
So you need to know what is the CK like, because Duchenne, by definition, is a breakdown of the muscles. If you're breaking down your muscles, you must have high CK. If you don't have high CK, then there's not muscular dystrophy. It might be something else. Okay, it could be spinal muscular atrophy. Okay, spinal muscular atrophy meaning that you got problem with your spine, and also it will affect your muscle power. Then in that case, then you want to do MRI, and you probably want to do a genetic study for muscular atrophy. So SCN1 gene deletion in that particular, if you suspect spinal muscular atrophy. The thing is, spinal muscular atrophy, you will see the signs from birth. Not obviously there is SMA type 1, type 2, type 3, type 4 anyway. So most of the time you see type 1 SMA, but normally SMA type 1 you see them from birth. Okay. And sometimes you can have a juvenile dermatomyositis. Dermatomyositis also can happen at any age in pediatrics, and they can come with proximal myopathy. But in that case, you also have high CK as well, but probably not as high as Duchenne, but at least high, like probably about 6,000 to 7,000, more or less 1,000 level of CK. In that particular condition, you also need to have muscle biopsy as well to look for sign of myopathy, inflammatory myopathy of the muscles. But those are the difficult cases. Okay. Other question? Remember to fill in the attendance sheet kan? Ada tak attendance sheet?
Ada attendance ke?
Dekat mana doktor?
Itulah cuba tanya Sister Hidayah kat mana nak tanya nak isi. So basically all of you present kan?
Yeah.
All of you present, kita ada foreigners. Foreigners tak apalah. Foreigners don't need to fill in the form lah. It's just the group 2 kan.
Yes, group 2.
Okay, any other question?
No.
Okay. No, eh?
Okay.
Oh, one last question. How to take history in a case of developmental delay? Is there any easier way to, rasa macam susah sikit.
Developmental delay, basically you just need to go bit by bit lah. So I normally ask question dulu when I was a medical student like you guys, we tend to remember all system lah, mana gross motor, fine motor, speech and social. Nowadays we just use the tick box here. So you got the checklist, you just tick box here. So those are the way that we're doing at the moment. So I don't really remember much in terms of definite history taking, but the easiest way is you need to remember from birth to 12 months old, from 1 year to 3 years old, from 3 to 5 years old. But you need to remember the gross motor, fine motor, speech, language, and also social. But you need to put into the birth to 12 months, 1 to 3, 3 to 5, and then whether it's delay or not. Okay. So for me, if somebody not walking by 18 months, then you start to worry. Okay, you start to worry, meaning that you need to investigate for what is the cause of the delay. If somebody not speaking by 2 years, then you start to worry. Okay, because first word should come by 12 months, but sometimes you live up to 2 years for first words, because sometimes they probably will start to speak by 18 months old, and but by 2 years old, if there is no comprehensive or there is no understandable words from by 2 years old, then you want to investigate whether they got any hearing problems or whether there is any other causes for the delayed speech. If they got social delay, then you need to think about possible autism. Then, so if they are not really smiling by 2 months old, then you want to assess their punya mata eyesight. If they're not smiling by 2 months old, because smiling should happen by 6 months. Sorry, by 6 weeks. If not smiling by 2 months, it's either Down syndrome or it could be the eyesight. So you kind of like knowing the stages of development, by doing that. So I don't remember from 1 to 12, 1 to 3 years old, 3 to 5, and I act accordingly depending on the presentation. Okay.
Okay.
It's almost 2.5 hours. I tak ada. So I think if there's no question, then I'm going to adjourn the session. Betul tak ada question?
No.
Okay, so we're going to adjourn the session with Tabliz Farah Sowas. Right, thank you very much.
Thank you, Doctor.
Okay, so we'll meet again at some point, and then we can arrange another session. I'll give you more cases. Okay, thank you very much. Okay, Assalamualaikum, selamat hari raya.
Selamat raya.
Thank you, Doktor.
Hari Khamis ni kita tak ada lah kan?
Asyik pergi planet mana
Esok pun
sih?
tak ada kan?
Seminar
Hari Khamis seminar je lah kan pagi kan?
petang.
Zati cakap pagi 5 petang.
Zati
Lepas
kenapa
kelima,
bukan pagi?
Bukan pagi ke Zati?
Kata
Zati.
5:30 tu.
Zati.
Zati tidur.
Pergi toilet
Tak
lah.
lah, Zati dah tak ada
Zati.
lah. Zati dah leave.
Oh,
Lol.
pagi tu tak ada seminar lah. Pagi Khamis.
Kiranya Zati
Seminar je lah ada.
seminar je, tapi Zati kata petang eh.
Dia dah
Pukul 5.
supervisor dah.
Jap. Kiranya pagi Khamis tak ada seminar.
Tak ada.
Time Zati.
Mengikut yang Zati kata tu tak ada lah. Dia kata pukul 5 kan, lepas pukul 5.
Esok pun tak ada apa-apa kan?
Esok tak ada.
So,
Kalau
Kita nak
macam kelas lain boleh.
Kita nak ada apa-apa ke?
join kelas lain kot kalau nak ada apa-apa pun.
Kelas lain.
Nanti
Dr.
inform lah.
Lagi satu nak tanya, apa nama? Hari Jumaat tu session dengan Dr. Ismail tu ada ke tak?
Prosedur tu.
Ada
Prosedur
kat dalam
presentation.
apa? Prosedur.
Prosedur presentation. Oh lah. Ada Wia?
Ya.
Azhan.
Ikut je lah.
Maman boleh live kot.
Asyik.
Okay, saya.
Kan nak buat efek tu.
Virtual background
buat virtual background.
Mana?
Asyik.
Oh boleh
Asyik orang buat
guna
virtual
ni.
Boleh.
Asyik buat
virtual
virtual
background?
background tu.
Cari dekat
ni
mall.
lah. Yang kat TikTok tu kan orang ajar tu.
Ya.
Boleh tepuk tangan lah.
Buat.
Okay.
Tak nampak pun
Ahmad ni
virtual
siapa?
background.
Kenapa?
Ada
Macam
cari dekat
macam
mall.
penanggal je.
More.
Ya. Tadi ke?
Tak ada.
More pun tak ada.
Apalah
Tahu,
kita
I
pasal
guna
live
phone.
tadi.
Meeting
Yang tak-
setting
Kafura nak TS meleleh.
Lepas tu touch up my appearance. Oh boleh touch up
Ya.
Boleh bagi
boleh
free
touch
tak?
up.
Orang buka pasar.
Ya, Amir, kalau Amir bisnes apa-apa nanti siap Amir
Orang buka
Boleh
pasar.
bagi free tak?
Kejap. Ada tengah cakap tu.
Attendance.
Tak dengar.
Attendance dalam ni.
Mana?
WhatsApp.
Okay, baiklah.
Orang kiranya next formal session kita petang Khamis.
Begitulah.
Ya Allah, dia dekat.
Kita dah ada 2 kelas. Sebelum ni tak ada attendance pun.
Itulah.
Semalam lah kan first official kita. Dr. Syed.
Jumpa efek
Tengok.
ni ya.
Tengok background I.
Jumpa apa sih nak edit?
Tak tahulah, ni guna phone.
Oh.
Tak payah Zan nak edit. Kau dah flawless dah.
Aku tidur dia sebab tu aku tutup kamera.
Lol.
Ya Allah, teruknya. Bosan
I
sangat
tutup
ke?
kamera. Aku tutup kamera
Ngantuk,
tapi
weh.
aku pergi order Grab food lah. Pergi ke dapur.
Ui ya.
Weh, hari ni
Ngantuk
kau
sangat.
sampai habis.
Hari ni time ni macam off sikit lah. Maybe sebab aku
Sebab petang kot.
sebab
Dia macam dah penat.
Masa panggil
Tak,
lah
aku macam tak ada
kata Amir
fikir.
tak ada.
Nak tanya.
Fokus.
Dah.
Nak tanya.
Okay. Aina.
Korang buat
Aida.
Ni
attendance tu korang letak apa? Long case lah.
Long case.
long case.
Dah.
Okay, jumpa next esok.
Next semester. Bye,
Bye.
Professor.
Macam nak leave ni? Oh,
Ada kanan.
tekan merah leave ni ke?
Yes.
Okay.
Baik Kak.
Ada hadi kita dua je ni.
Tak, saya nampak.
Nampak lah awak. Syugi ke esok? Ada momen lah. Okay lah, baiklah. Last year. Bye.
Bye-bye lah.
Tak henti. Sekejap. Satu, dua, tiga.
Kami suruh rambut gitu ah. Kami suruh rambut gitu ah. Kami suruh rambut gitu ah. Kau menang pasal gitu kecil lah.